Dr. Libby Sallnow. Now, she lives in London NHS Trust, and she's an academic working at St. Christopher's Hospice, in Brussels, the Free University, University College London, and also the WHO Collaborating Center in Community Participation in Palliative Care, Kerala, India. Now, I am so grateful, Libby, that you decided to join us today, because we need someone like you as the lead author to unpack for us this huge report. Amazing title, Bringing Death Back to Life. Welcome, Libby.
Thank you. Thank you. Let me just share my screen. Great. Can everyone see that? Great. So it's a huge pleasure to be here today from early morning in London, and thank you very much for the opportunity to present some of the findings. As Samar has said, this huge report, it started off much larger, I can tell you. It's the edited version down to the 25,000 words that we eventually published. But I've got the next kind of 40 minutes to talk you through the different areas, kind of why we pull certain themes through, some of the key recommendations, and this idea of a realistic utopia that we tried to come to at the end. So as Samar said, I'm a palliative care doctor. I work in the community in London, seeing people at home, and I'm also an academic at St. Christopher's and at University College London, and at Free University in Belgium. And great to see some people from there online today. Hello. So the first bit I want to talk about is looking at what the impetus for a commission on the value of death. And as we know, the Lancet do many different commissions on complex, thorny issues, but they certainly have not tackled anything like death before. So the reasons were that death, dying and grief are core universal human concerns, but actually how people die has changed significantly over recent generations. And we see this more so in high income, but increasingly in low and middle income settings. Some changes have been for the better. So we look at people are dying later in life, life expectancy has increased, many conditions that were previously fatal are now curable. And some around the world have access to pain and symptom relief as they die. But some changes have been for the worse, and dying is now prolonged. We see people increasingly dying in hospital, disconnected from the networks that we've heard so much about from this morning. And there's increasingly the sense, both in the literature and anecdotally, that people, communities, families feel unprepared when they begin to face these essentially universal human concerns. So the Lancet Commission on the Value of Death was formed in 2018. It was made with 30 commissioners across 12 different countries, a range of people beyond healthcare professionals. The Pain and Palliative Care Commission had been published in 2017, and there was a very clear sense that we needed to make this not about palliative care provision, not about healthcare provision at the end of life, but actually about the idea of death and dying in that broader sense. So we had authors, social scientists, researchers, philosophers, religious leaders, economists to bring multiple different perspectives into this. And as I said, it looked beyond the kind of provision of care and the provision of services to look at a much broader, through a much broader lens of how these times are experienced globally. So it was a huge remit. And we had to begin to try and kind of tether some of these different perspectives together. It was very interdisciplinary from the outset. And so we came across the idea of thinking about death and dying in a systems approach, and using this systems thinking and a systems lens to begin to understand the broad, multifactorial, intersecting challenges that influence experiences at these times. We wanted to look at some of the really broad determinants of what's happening when these experiences take place. And so we looked at structural issues such as gender, race, power, discrimination, alongside access to healthcare services, philosophy, consumerism in healthcare, and economic perspectives. The key messages from the report, they're at the front, and I think it's quite helpful to kind of tailor some of the talk around these key messages. So the first one is that dying in the 21st century is a paradox. And as we began to look at the core contention, which is that death has essentially become over-medicalized and over-professionalized, we began to unpick that actually that's not the case everywhere. And for some places, people are not accessing the right healthcare, which would lead to prevention of avoidable mortality. And actually, there needs to be more healthcare in certain areas. When we look at palliative care, only 14% of people globally in the WHO, according to the WHO, can access morphine or pain relief as they die, or even looking at broader palliative care services. So it's not the kind of true to say that actually all healthcare needs to step back, and we need to kind of look at social models. We need different models in different places, and so it's a paradox. Some in high income specifically, patients and people are being overtreated in intensive care, building advanced directives to try and reduce the amount of care they have, whereas other places, often in the same country down the road, people are not accessing the right care. And so that's influencing how, where, why, and when people are dying. Death, dying, and grieving today have become unbalanced. This is one of the core contentions, that the balance between healthcare, social, community has shifted, and that has become unbalanced. We make some very explicit links with the climate crisis and looking at the common delusion that we are in control of, not part of nature, leading to a lot of the current issues around essentially immortality and the pursuit of endlessly deferrable death, and that the links with the climate crisis have the same contention, that we are in control of death and not part of death as part of our natural lives. Rebalancing death and dying depends on changes across death systems, death, dying, and grieving systems. And these are the same systems that look at education, financial systems, hospitals, families. These complex systems exist in many parts of our lives, and that's no difference in end of life and death and dying. As with all systems, the disadvantaged and powerless suffer most. And in fact, many systems are designed to recreate and perpetuate the status quo. But we wanted to move to look at a hopeful outcome, and rather than looking at tracing just the challenges of death and dying, which are well rehearsed and well known, we wanted to look more hopefully and more intentionally to how we might change the future of dying. And so I'll come on to this in more detail, use the principles, the idea of a realistic utopia, a new radical vision, but achievable vision of how death and dying could be in the future. And we acknowledge that the challenge of transforming how people die and grieve today has been recognised and responded to many around the world. And in fact, here today, we're hearing from many brilliant examples of how that's happening around the world. But more action is needed, as I saw in the chat. This needs to be available not just to lucky communities. This needs to be a core availability for all those people facing these challenges. And a reminder that radical changes across death, dying, and grieving systems are a collective responsibility. They don't sit with healthcare, they don't only sit with communities, they don't sit with policy, government, they sit with everyone. These are universal human issues that must be responded to by us all. So I'm going to start by just looking at some of the facts and figures that we collated to give a picture of what death and dying is like in the 21st century. So on the surface, global mortality and life expectancy trends in recent decades have improved, and it appears to be a success story. People are living for longer. But when we look deeper and scratch beneath the surface, there's disproportionate progress both across countries and within countries. This is particularly seen for specific population groups such as women. So in the UK, women with the most deprived socioeconomic status bracket, they have seen their life expectancy not only stall, but actually reverse. And we obviously saw this in COVID, and the same can be seen in the US for women with fewer than 12 years education. Their life expectancy trends are no longer increasing, and in some cases reversing. And when we look at the idea of healthy life expectancy, not just life expectancy seen as years gained, healthy life expectancy is the years lived in self-reported good health, we see that actually it's not kept pace. So whilst people are living for longer, those years are not lived in good health. We see a shift of disease from communicable to non-communicable diseases. This has been well established in the majority of high-income countries for many years, the epidemiological transition. but is being undertaken very rapidly in countries such as Bangladesh, where we see huge reversals and changes from cause of death and main illnesses from infectious, communicable or accidental to chronic non-communicable conditions such as heart failure, CVA, etc. And that sudden shift basically asks a health service and a health response to respond to something completely different in a very short space of time. And these are very underfunded services. So this huge shift created an entirely new set of questions. And we wanted to build on the Lancet Commission into palliative care and pain relief, which categorizes and captures this idea of serious health-related suffering. And that this health-related suffering is not only experienced in the final months or even last year of someone's life, but can in fact extend and be experienced in many years prior to death. This is a table from the report looking at countries that that commissioners were from. So as we were talking in Zoom groups, we were looking at what the differences on our own countries were. And here we can see, looking at overall life expectancy between a colleague, a GP in Malawi, and the UK, where I was coming from, nearly 2 decades of difference. So although there are broad trends of improvement, there are still stark differences across countries. And this table begins to look at some of the differences around maternal mortality, deaths from suicide, deaths from non-communicable disease, deaths from communicable disease, and serious health-related suffering. And just showing that actually the picture is hugely different in different countries. And actually the context of how, where, why people are dying must be taken into account to understand how we even begin to challenge and address some of these issues. And so we wanted to really focus on the social and structural determinants of death, dying, and bereavement. And these terms, social and structural determinants, is often associated with health and well-being. And there's been a huge amount of work, mainly by the WHO and other colleagues, who have written to say, health is not determined by the services that we use and the medications that we take. And this has now become really well established, and the multifactorial sense of how we improve health and well-being is well established. But those same determinants are used and determine how people experience these times. The idea that actually education, discrimination, access to services, access to food, those same issues that have determined health and well-being, of course, continue to go and determine the experiences when someone's dying. And the differentials in distribution of power, resources, unequal environmental, socioeconomic conditions, discriminatory policies, and lack of an intersectional lens, all of those things continue throughout life, throughout health and well-being, and into death and dying. It's this kind of idea of a life course approach that we must take. So we came, when we were trying to kind of bring some united messages, some key messages that we wanted to bring from the Commission, we came to the central paradox, as I've mentioned. And so here, this is a picture on the left from my intensive care unit in University College Hospital in London during COVID, where we see kind of the ultimate medicalised death. People are not with their friends and family, they're masked and gowned clinicians, there's no human connection, there's no sense of this person as their own person, it's around their biochemistry, their physiology, and the machines in the treatment. And we don't know how much this person would have wanted, but there's a sense that actually treatment continues unless it is stopped, unless there is a reason to halt it. Whilst we look at other countries around the world, and this map here is from the Lancet Commission into pain and palliative care access, and it's a map showing the amount of morphine that is available per person who needs it per year. So this isn't the amount of morphine available to the country in general, it's how much that person who needs palliative care, how many milligrams per annum they can access. Looking at Canada and Australia and USA, they're bloated, they've got 60,000 milligrams per annum per person. And the UK and Australia kind of, almost normal size, but stretched in some way. And then entire continents are reduced to a thin line of India, Russia, Africa, South America. And so this demonstrates the kind of stark inequity that exists globally, even in something as a very poor proxy for end-of-life care, but the availability of morphine for people with end-of-life care needs. And the answers to this are obviously not straightforward. This is not something that we could solve with the provision of a new service or the provision of a new community intervention. These are complex, nuanced, established and entrenched situations that stem from the complex systems that control them. So the iceberg model is quite a good way of kind of beginning to understand the structural challenges that really determine why these experiences are as they are in different contexts. Looking first, you take the top, kind of the highly visible part of the iceberg is the events. What is happening? It might be that people are dying more frequently in hospital than they are at home at the moment. And that might be the trigger to say, okay, well, let's look to understand a bit more about how this happened. You then go deeper at one level to look at the patterns or the trends. So, what have been the changes over time? What's happening with this event? And you begin to see what is happening increasingly in high-income countries quite recently over generations. And there are trends within cities in low and middle-income countries that the same is happening. We see that increased spending is taking place in the last months of life, and that this is a relatively recent trend again. You then go to look at a deeper layer, to look underneath at the underlying structures, forces that are kind of determining these patterns and influencing these patterns. And here we see things like increased life expectancy and people now dying of chronic rather than acute illnesses. The fact that many previously fatal conditions are now curable, so people are living longer. And this is really shifting expectations of what people think about death and dying, and also their familiarity with seeing someone who is dying, or caring for someone, hands-on caring when they're dying. Increasingly, this just isn't happening. This is happening out in institutions whereby families are not involved in that direct care. So that's again shifting the kind of narratives and the kind of mental models as we go down to the deeper one, which is the kind of paradigms, the kind of sense of what is happening in terms of how people really view death and dying, what value of death means, what a good death means. And here we see increased hospital treatment, giving this sense that there's always one more treatment, that there's always one more thing that will defer death that's available. This kind of belief in modern medicine's almost been equated to kind of a modern religion. Sense of what value of life is, and the sense that actually giving someone more hospital treatment, one more treatment often is equated for many people in valuing that person, valuing that loved one. And ideas of what a good death are. Is it at home being surrounded by your family, or is it kind of fighting to the last in intensive care? And this all links to that kind of deeper idea of our immortality, and why it links back to ideas of mastery of nature and climate change, that we can somehow one day will defeat death, beat death, and that we're in charge and in control of this part of our lives. So this kind of looking deeper and deeper and asking questions at each level, why is this happening? Why is this happening? Gives a frame for how we can begin to understand the events that we see today, which are essentially the tip of the iceberg. So taking a systems approach is acknowledging and addressing the interconnected nature of different events, of how people have lived their lives, the work they have, their employment, school, religious community, cycling groups. This is all part of a complex and interconnected lived reality of someone's life. And this kind of non-linearity is really crucial. Introducing something from here to here and expecting A to always equal B is just not going to happen in the complex real world. So, this for someone's life may lead to one outcome. If we did the same thing for someone else, it will lead to something else. When you really look at a real world impact of something, you cannot presume it will always be the same. So non-linearity is a really key component. It's the relationships that exist between components that are central. And there's emergent and predictable behaviours and systems. They have a life of their own. They're constantly evolving and changing, but often they do maintain a status quo, which can be good or bad, depending on your position within that system. And then leverage points exist for significant change, where you can make quite a small shift to the system and actually have quite significant change. Now, we're not the first people to come up with the idea of death systems or death, dying, and grieving systems. And Robert Kastenbaum, a US academic, was first used this term to describe the interpersonal, socio-physical and symbolic networks through which an individual's relationship to mortality is mediated by society. And that's how he framed and defined the term death systems. And he describes this framework that there are means for death and dying to be understood, regulated and managed. They often define the meaning of death in the culture or community for which this is taking place. They determine where people die, how they mourn, the norms and the socially sanctioned ways that these experiences are publicly experienced. They encompass different components, places, symbols, and they have functions. So there's parts which is, climate change and public health, things to warn and predict death, protect against early death or avoidable death, also care for the dying, making sense of death. And they exhibit dynamic complexities. They are constantly changing, constantly evolving, and constantly moving. And so the rationale for really using this is that we, at the moment, looking at a lot of our health services research and a lot of the kind of more positivist ideas of new studies to evaluate a new service, often they're using linear thinking, kind of really reductionist reasoning and just static options, not taking account of this much broader dynamic context. And these fragmented approaches can lead to real inefficiencies, unintended or negative consequences, and real inequities. So there's a real driver for bringing together this kind of multifactorial way of change, but also the kind of intersectional aspect of people's lives, that people don't experience things in separation, they experience things as a whole. So this is one picture a diagram that we included in the commission. It was included to illustrate its complexity and the almost impossibility of trying to comprehend the entire whole. So it was not meant to be a map for us all to start working from. And it's one point in time, as all of these maps and kind of diagrams, they just demonstrate an example of how this would be in one context. And this is for dying at home and looking at the huge multitude of different components that feature here. And so if we're looking at rebalancing death, dying and grieving systems, shifting these systems, then you obviously need an integrated approach looking at societal, healthcare, legal, amongst many of the different aspects. And that it's essential to understand, if not intervening in all of them, to understand the integration of all of these different approaches. So once we had kind of looked at the different challenges and we had outlined many of the current issues facing death, dying and grieving today, we wanted to then describe, well, as we said, these systems are constantly in flux and are constantly changing and responding to other broader societal changes. So we wanted to bring the idea of scenario planning in to give people a sense of what may happen if we do not intervene. If we do not take any action or change things, systems will evolve themselves regardless. And so we use the technique of scenario planning. So it's not formal systems modeling, it's imagination, looking at the different drivers that are happening currently and extrapolating them through. And so we came up with 5 different imagined futures for what death and dying systems might be like in the next kind of 30 plus years. We wrote the commission through COVID, but wrote these prior to COVID. And some of these scenarios actually came true during the pandemic. So for example, death overwhelming health systems, whereby the need for healthcare or the number of people dying was too much for healthcare services in northern Italy and in India, amongst other places around the world, for them to manage. And we look at some of the other ideas of immortality, the approach to immortality gaining ground and people actually being able to access extension of their life for huge cost, huge amounts of money, and what this would do for global inequity in terms of life expectancy and access to resources. We looked at the role of climate change and whether this might prompt a reckoning, a kind of greater equity and fairness in use of resources and understanding the climate footprint of escalating end-of-life care, inappropriate treatments. Otherwise, we looked at where things may be rebalanced, a more hopeful scenario, and looking at the role of assisted dying in countries where it currently is not practiced, but understanding there's changes across many jurisdictions changing that, and that introduction would shift and be an important change within death systems to understand. But again, we are not passive in this work. We are all part of these systems and have the ability potentially to change them. And so we wanted to think more intentionally about one of these, which of these scenarios or many other ones would we want to actually take place, and how could we begin to work towards that? So we came up with the idea, borrowed the idea of a realistic utopia from the philosopher John Rawls, the US philosopher, who describes this, a realistic utopia, as joining reasonableness with justice and with the conditions that enable citizens to realise their fundamental interests. And what he essentially described was thinking radically about what would be a society that you would want to live in, that we would want to be part of, that we could imagine would be the best kind of realization of all our interests within that. But whilst it being radical and hopeful, it also is practical. So it's something that can be achievable within the confines of our system. So it's a radically different future vision of future society. And it looks at profound rather than incremental change. This is not kind of tinkering around at the edges. This is really looking for profound change across death, dying and grieving systems. And it's based on shared vision and principle. And that's the kind of the first premise, to understand what these first principles are and then begin to enact them in a variety of different contexts. So I'm going to talk through now the 5 principles for our realistic utopia that we came up with and that we designed. And these are high level, so these are necessarily high level to allow them to have relevance for all contexts globally. And so the idea is that we present these high level aspirational principles, and each context then looks at what that would mean for them and how they would then begin to put that into practice. And there are examples, before we go into that, of this happening around the world, and we capture them, and I'll come back to some of those. So whilst this is something that is quite utopian, I don't mean that in the kind of derogatory term of that. Actually, this is already happening. This morning, this afternoon, you've already heard of many of these different examples happening in places triggered by people around the world. So the question is, how can we make this something that is universally accessible, that is universally understood as essential? And that's what the 5 principles start going some way towards. So the first principle comes back really to the social and structural determinants of health, kind of understanding the life course approach, and that death, dying and grieving are a standard unmovable part of all our human condition, and that this has somehow been forgotten and lost in much of the debates on how we improve our environment, our health and our well-being. So how people live, the lives, conditions of their life and their health during that time, those determinants have impact into how, where, why, when people will die, the experiences of that dying, and how those around them experience that. Then how people die obviously has a huge impact on how people grieve, how those people who are left behind, how they experience their life going forwards, the role of their grief plays in their life, and how that dying took place influences that. And then knowing how people are grieving, the experiences, the resources they can draw on or not, their understanding of the loss of that person, etc., that has a huge impact on their future life, on their return to work, their mental, physical health, their ability to maintain, form, connect, have relationships in their community. That feeds into their living, and that in turn affects their quality of life, who they are, their health and well-being, which then will go into effect their subsequent death and their subsequent any other supports that they may be having around people dying. So this kind of interconnected nature is something that we very much take for granted and we understand in the fields here, but actually looking at the social determinants of health literature, this is not something that's included. If you read The Social Determinants of Health by Michael Marmot, it goes through early years, education, employment, retirement, and just ends. There's no sense that there are any further life stages past dying, past retirement, and there's an urgent understanding to see death, dying as part of the life course, and not just palliative care's responsibility, not just certain community groups' responsibility. This is something that needs to be taken seriously by everyone across the life course. So our first principle is that we must first understand these social and structural determinants and then begin to tackle them in whichever context they are being manifest where we are. The next one, again, speaking to a highly converted audience, I would think here, but dying is understood to be a relational and spiritual process rather than simply a physiological event. And that, again, obviously is something in palliative care or in the kind of allied work that we've heard about today, is something that is deeply and fully appreciated, but something that is entirely almost forgotten, I think, in hospitals at times. There are times when people can die well in hospital, but certainly a lot of my experiences have been of disconnected, isolated, prolonged dying that is only looked at through the markers of biochemical physiology, and the kind of personhood, meaning, purpose, relationship, spiritual ideas are quite hard to bring into hospitals. Not impossible, but quite hard. And even at home, there can be times when actually these are not brought in. And so the focus has to be on the relational aspects of dying and bringing in the other parts around the physiology as interesting, important, relevant at different times, but not the fundamental driving understanding of what dying is. The third principle looks at networks of care. And this is a real fundamental principle for this. And we often see good examples of networks being developed around certain people who have got the resources, the skills, the connections, and the support to do that. And we see many other people who are deeply isolated and have none of these resources, none of these connections. So what the priority is to begin understanding how these networks can be formed around every single person who is dying, every single person who is grieving. And these networks need to be truly kind of integrated across health and social care. And obviously there are some crucial parts of having, you know, the right team around you, but then the right community resources in terms of people supporting cooking meals, taking dogs for walks, community pharmacy, post office, postman, etc. And then that inner family of understanding how they're supported, who are the main carers, how are people being supported. And often what we see, and there's a lot of literature to suggest, is that these relationships, that there are very limited relationships between these sections of networks. Many people may have aspects of these networks there, but there's absolutely no connections between the different parts. And essentially, if we kind of take the systems idea and put that onto the networks around someone's dying, they are exactly the same as a system approach on a city level. Looking at that microsystem, how can we understand not only who the components are, but what the connections are between across disciplines, across communities, across different parts of that person's life. So that the urgent requirement is to begin understanding how we can make connections, how we can join up these networks. We found in our commission research that many many reports, strategies, guidelines from the WHO on healthy aging, reports on liver disease, frailty, etc. COVID-19 absolutely omit the idea of dying from any of these conditions. So it's just not included. So COVID-19, healthy aging, etc. There's a sense you just continue. The focus is on rehabilitation or on ventilators, which obviously are essential components. But there was a real silence and an omission of understanding that death, dying, and grieving will be part of all these healthcare conditions, yet alone are a part of normal, the fabric of normal everyday life. We also see how, whilst death is in some way sensationalized, on the front page of newspapers, it's the main line in TV programs, films, books. You know, death is somehow, in some ways, everywhere. But dying, as Catherine Mannix calls everyday dying, from heart failure or cancer in your living room at home or in a care home, that is something that's deeply unfamiliar and is not covered and not presented in the general narratives that people have access to in society. And often people I care for at home feel like this has come out of nowhere. They're suddenly confronted with something that is so unknowable, so unfamiliar, and that they feel so unprepared for, because they essentially have no script. This is something that they have not often witnessed with older parents and families. People haven't died till much later in life. So this is something that hasn't been part of their life. And because it's not presented in any of the kind of more formal policies and reports or media stories and storylines, there's no way for people to find this out. So we want to ask that conversations and stories about everyday death, dying, and grieving become common across the spectrum, from media, stories in films and on news items, right the way through to formal strategies and policies. And this silence, this omission of death and dying must be addressed. And finally, probably the most abstract and in some ways hardest to articulate, the principle to look at the idea that death in itself has value. Now, this is not to say that all death, premature, avoidable death, has value. And this is not looking at individual deaths to say they have value, but this is looking at the concept, the idea of death in our lives. It has value. It bookends our lives. It is part of the survival of a very crowded planet, that actually we cannot all live infinite lives. And the idea also of caring for the dying. There's been a huge amount of literature going back thousands of years to try and capture and articulate the value that caring for people at the end of life, of that essentially shared commonality, that shared vulnerability and fragility, of the value of that time, both for that person dying, but also for those caring. And the value that then you take away, having considered, actively cared for someone, supported them. And we heard this in some of the talks this morning, that you take that away, you reflect on your own life, and actually that allows you to live your life in a very different way, and for many people, an improved way. So death is integral, death has value, and death must be understood as a part of our essential human condition. I want to finish with, this is one of the last tables in the Lancet Commission, I think my favourite, coming back to the idea of the kind of green shoots of the realistic utopia of change in the field happening around the world. And here we put in some of the ideas of how you shift change in systems, the leverage point in systems. So transforming the mindset, changing the rules of the system, changing the way information is held. And we categorize what this would look like for an end-of-life care, death and dying context. And they just give examples in the final column of where this is happening, where huge amounts of action, energy and input are coming in. So it's happening essentially, the roadmaps are there globally. The question is, how do we begin to make this something that is universally accessible, universally understood as important, and crucially moving beyond our palliative care world, where we really understand and accept these challenges, and moving out to a much broader audience, both kind of professionally, policy-wise, but also into the broader public. Thank you.